Hi everybody. I am Aws Al-Farsi, final year ME student at the College of Medicine and Health Sciences from Sultan Qaboos University, Sultanate Oman. So it is an honor really to be here in Rome and present this study, our study, which is titled The Burden of Human Parechoviruses on Children in Oman, a retrospective study. So this is the outline of the presentation. So let's start with a brief introduction about human parechovirus. So human parechovirus is a non-enveloped positive single-stranded RNA virus from the family Picornaviride. It can cause gastrointestinal, severe respiratory, and central nervous system infections in children. And the mode of transmission is through respiratory droplets or fecal-oral route. And clinically, children with human parechovirus may present with fever, irritability, and rash, and they are described as hot, red, angry babies. So there are two species of human parechovirus. We have parechovirus A and parechovirus B. Parechovirus A is further divided into 19 genotypes, and the genotypes that are associated with human disease are 1, 3, and 6. Human parechovirus type 3 usually causes the most severe symptoms according to previous studies. So the aim of the study is to identify all confirmed cases of human parechovirus infection among children presenting to Sultan Qaboos University Hospital, which is a tertiary healthcare facility in Muscat, which is the capital of Oman, describe their clinical and laboratory features and outcome of the virus. In regards to the rationale of the study, so far data regarding human parechovirus in Oman is scanty. Published studies, they are mainly from Western countries. So therefore, the results of the study will help pediatricians in Oman and in the neighboring countries to get a better understanding of the burden of this virus in the region, especially the Middle East. So regarding the specific objectives, we have two specific objectives. The first one is to describe the clinical and laboratory features and outcome of human parechovirus infection in children at SQH. The second objective is to identify possible epidemiological patterns of human parechovirus in Oman like seasonality. So regarding the materials and methodology, the design of the study is retrospective. Data was collected from the electronic patient medical records, which is known as trachea, and it was collected through Excel sheet and also an SPSS sheet. Consent was not required since the design of the study is retrospective, and also data was stored in computers with passwords that are only accessed by investigators. Regarding the sample size and the study period, the study included all consecutive cases from January 2017 up to December 2019. The study included all symptomatic children aged less than 18 years old with a positive human parechovirus PCR from respiratory or cerebrospinal fluid specimens. The exclusion criteria is as follows: asymptomatic children and patients with missing clinical data. The ethical approval was obtained from the Medical Research Council Committee at the College of Medicine and Health Sciences in May 2020. So data was analyzed through SPSS version 25 for descriptive statistics, numbers and percentages for categorized variables, median and interquartile range for continuous variables. We used chi-square or Fisher's exact test for categorical variables, Mann-Whitney U test for non-normally distributed continuous variables. And a p-value of less than 0.05 was considered statistically significant. Data was presented through tables, line chart, and pie chart. So moving on to the results of the study. So starting with the demographic characteristics of our study population. So we had a total of 63 patients. 2 patients were excluded due to insufficient medical data in their records. The male to female ratio, as you can see, is 2.5 to 1, which is similar to what has been described by studies from Iran, China, and USA. And regarding the age, the median age is 9 months, and the interquartile range is between 6 to 15 months, which is similar to what has been described by an Australian study that have shown the median age to be 8 months and the interquartile range to be between 6 to 12 months. And this increase in cases, this increase in susceptibility to human parechovirus cases after 6 months might be explained because of waning of immunity provided by the maternal antibodies. All of our patients were of Omani nationality. So regarding the comorbidities, the most common comorbidity seen in our cohort was prematurity, 10 patients were premature, followed by asthma in 7 patients. And then we had patients with other atopic disease, patients who were immunocompromised with neurological impairment, sickle cell trait, and also congenital heart disease. So moving on to the seasonality of human parechovirus in Oman. Human parechovirus was detected throughout the year with a relative increase in cases in both winter and fall months. And this increase was not significant. It was by 1 to 2 cases, as you can see. This increase might be due to opening of schools and also the probability of having different human parechovirus genotypes circulating in Oman, resulting in different seasonality patterns. And also it could be because of the decrease in temperature from late summer to winter. And this is similar to what has been described by an Iranian study that showed that there were no significant differences between the various seasons. However, studies from Hong Kong and Australia showed very clear seasonality compared to what was seen in Oman. So viral co-infection was very common in our cohorts. 51 patients, about 84% of our cohorts had co-infection with other viruses. The most common virus was rhinovirus with a percentage of 49, followed by adenovirus, and then RSV and enterovirus. And this is similar to what other studies have shown. So regarding the hospitalization status, about 48 patients, 79% of our cohort were hospitalized, and about 39% were admitted to the regular ward, 28% to the high dependency unit, and only 12% to the pediatric intensive care unit. So regarding the outcomes, none of our patients developed sepsis, acute kidney injury, or liver dysfunction. All of our patients had full recovery. None of our patients died. 2 patients presented with febrile seizures. They did not have any previous history or recurrent events in the future. So both 7 months and 12 months old. So as I said earlier, that viral co-infection was very common in our cohort. 51 patients out of 61 had co-infection with other viruses. So we did a comparison between isolated human parechovirus and human parechovirus with co-infection to see if the co-infection group had more severe symptoms. So regarding the male gender and the age, no significant differences seen between the 2 groups. As you can see, the p-value is not less than 0.05. So regarding cough and rash, no significant differences seen between the 2 groups. Regarding wheezing, it showed a lower frequency trend among the isolated human parechovirus group. However, it did not reach statistical significance as the p-value was 0.075. Regarding documented fever, tachycardia, and tachypnea, no significant differences seen between the 2 groups. In regards to the hospitalization status, no significant differences seen, as you can see. In regards to seizures, no significant difference, but the 2 patients that presented with febrile seizures were among the co-infection group, and none of our patients died. So in summary, human parechovirus infection was detected throughout the year with a relative increase in cases in both winter and fall months, but it was not significant. It was by 1 to 2 cases, as I said earlier. Most of the children who were less than 2 years of age and had a viral co-infection. Outcomes of human parechoviruses were favorable with no mortalities, but thorough follow-up of neurological outcomes was lacking. So this study has a number of limitations. So the first limitation is obviously the relatively small sample size. And this could be because data was collected from only 1 center, Sultan Qaboos University Hospital. And also not all patients presenting with respiratory symptoms are tested for human parechovirus, which makes it likely that there is an underestimation of the number of human parechovirus cases reported in our study. Another limitation is the retrospective design of the study. So some patients had incomplete medical data in their records. In addition, the human parechovirus genotypes were not identified, and hence it is not possible to compare the severity among the different genotypes and also the seasonal distribution. Furthermore, the presence of co-infection in most of our patients makes it difficult to make sure that the clinical picture is fully explained by human parechovirus. Future work includes conducting a multi-center study in Oman to assess the burden of human parechovirus infection among children, especially neonates. Other future work includes conducting studies on human parechovirus genotypes in order to have a complete understanding of the burden of human parechoviruses on Oman's healthcare facilities. So finally, I would like to thank Dr. Leila Yazidi for her supervision of the work. I would also like to thank Dr. Zaidin Hinai from the Department of Pediatric ID. I would also like to thank Dr. Fatma Ba'alawi and Dr. Khulud Ma'mari from the Department of Microbiology and Immunology for their feedback. So these are my references, and thank you very much.